did have my face shield. I had to take it off for this purpose. However, having on your face shield, your mask, and gowns like this is very uncomfortable. It's very hot, you know. So, talking about the comfort of the doctors and the staff working with these patients is very difficult for us where that is concerned. Just continue observing the protocol that the ministry has put forward, right? And that will include mask wearing, hand washing, frequent sanitization, and just social distancing.
Good evening, ladies and gentlemen, members of the media. Thank you so much for joining us for the Ministry of Health and Wellness's COVID Conversations for Thursday, September 9th, 2021. The Minister of Health and Wellness, Dr. Honorable Christopher Tufton, is joined by the Permanent Secretary, Mr. Dunstan Bryan, the Chief Medical Officer of Jamaica, Dr. Jacqueline Bisese McKenzie, and Dr. Melody Ennis, the Director of Family Health Services in the Ministry of Health and Wellness. We'll begin this evening's conversation with the update from the Minister.
Thank you very much. Thank you very much, Stephen. Good evening. Ladies and gentlemen, thank you very much for joining us at this COVID conversation, and to my regular team members who are here, and to the rest of you who are listening on. I would like to begin by reporting that today we confirmed, that this is the Ministry of Health and Wellness, through tests that have been done, the presence of the mu variant in Jamaica. Some 26 of 90 samples tested and received today confirms the presence of this variant strain locally. And I will ask the CMO shortly to expand on the implications of this new variant strain that is now confirmed present in Jamaica. I'd like to also comment on the genome sequencing machine, which I know has been discussed on a number of occasions. We can say that we have made significant progress in the acquisition of at least one, possibly two of these machines and the reagents that are necessary. And we expect arrival in the country within the next 2 to 3 weeks. And this, of course, will allow us to test for variant strains without having to send samples to locations overseas. And so that is a good development based on discussions that we have had with the suppliers over the past few days. I'd also like to announce that after tomorrow, September 10th, 2021, the ministry will be suspending the administration of first doses of the Pfizer vaccine. This is to ensure that the inventory of Pfizer vaccines that we currently have, we can guarantee a second dosage for those who have already had their first. The reason for this approach is because we have not yet confirmed the arrival date of the second shipment of Pfizer vaccines from the United States. Remember, this was a gift to be delivered in tranches. We got the first 200,000+ doses. We have used up approximately half of that. And the period of time that it takes to administer the second dose is 3 weeks approximately, unlike the AstraZeneca, which could be from 8 to 12 weeks. And so because of the uncertainty of the arrival of the second shipment, we want to ensure that those who receive their first dose can get their second dose within the period of time that is stipulated. And so we will provide further details later on into the weekend. And as soon as we have a confirmatory date for the arrival of the second shipment of Pfizer, then we will resume giving first doses for those who prefer that particular brand. Of course, it will also have implications for our 12 to 18 years. And so we're hoping, and we have inquired, we're waiting on word from the US, we're hoping that the confirmatory date will not be very long from now. But we will keep you informed as it relates to this particular development. All persons who are due their second dose of the AstraZeneca and Pfizer vaccine this weekend should by now have received text messaging indicating the time and the location. If you have not yet received a text message, then you can go to a vaccination site that is open. And so while we prefer appointments, if you are due, we will accommodate. And so I want the public to bear that in mind. Persons who were vaccinated at St. George's College and are due on Saturday, September 11th, 2021, are asked to go to the National Arena to get their second dose of the COVID-19 vaccine. So those who went to St. George's College, please go to the National Arena. Our vaccination numbers are increasing steadily. I really want to thank the public health team, the supporting team members, the constabulary JDF, the administrators who have really been hitting the pavement and providing as much opportunity as possible for Jamaicans to benefit from vaccines. As of 5 p.m. today, 5 p.m., we have administered some 612,809 doses of vaccines. So 612,809. Of that number, 459,040 were first doses, 141,495 second doses, and 12,274 single dose, which is the Johnson & Johnson. These numbers put us within the target that we had originally set and announced, which is to achieve 700,000 doses of vaccine by the end of this month, meaning September, in pursuit, of course, of the goal of the 65% of the Jamaican population vaccinated by March 2022. So we are within reach of that target, and again, it is due to the sterling efforts of the team in the field, the long days, nights in some cases, and of course the Jamaican people who are coming out. Now, the September is going to change fairly significantly in terms of the percentage of the population with a full dosage because of the significant numbers that have had first dose, 459,000, many of whom are due for their second dose in September. And so this month will be a very active month, and if all goes to plan, at the end of September, you will see the complete vaccinated percentage of population, I think, perhaps doubling from the 5 or so percent where it's at, closer to maybe 12 to 15%. So you'll see a quick jump, and that's because most of the population that have had their first dose are now due their second. So it is going to be a logistics challenge because we're going to have to go for second doses and first doses. And that clearly will mean more outlets, greater efficiencies, and we'll comment more on that. But the population can rest assured that you will see a fairly significant increase in the overall completed vaccinated at the end of September because of the focus and the due dates for second dose. Critically, the current risk management protocols, notably the curfews and no movement days, we think are reaping some rewards. In the last day, for example, we recorded 511 new cases of infections with a positivity rate of 32.5%. The CMO will comment more on that, but clearly moving from over 50% now down to 32. And if you look at the 7-day average, you'll see a trending down. It's an indication that the sacrifices that we're making as a country, as a people, is paying some dividends, and that's something to remain hopeful about. At this time, let me ask the CMO to elaborate on some of the things I've said and some other details around the data for COVID. CMO.
Thank you, Minister. Good evening to everyone. We're going to go through the presentation, and during this presentation, we're going to try to answer some of the questions that we recognize are in the public space. So we have a few slides. Okay, so our data is of September the 8th. As Minister has indicated, we did confirm 511 cases yesterday, and that now brings our total confirmed cases to just over 74,000 confirmed cases. We have 1,685 deaths, and that is overall a 2.3% case fatality rate. Daily positivity rate is 32.5%, and the positivity rate, the 7-day average, is 38.3%. So certainly it is going down. This set of slides look at what is happening across the parishes to indicate that the problem that we're facing is right across the parishes across the country. We see in the top figures the numbers of cases that we've had in the different parishes since the beginning of this pandemic started to affect Jamaica. And then the bottom gives you the active cases over the last 2 weeks, those cases that are confirmed over the last 2 weeks. So if you look for your parish, you can see how many cases you are seeing, and you will see that the highest number of cases are in Kingston and St. Andrew, and in St. Catherine, and in St. James and St. Anne. However, if you look at the number of cases per population, because some parishes have a larger number of persons and therefore will have a larger number of cases, but a calculation is done of the number of cases per 100,000 population, and you will see that where we have most of the cases per population is in the northwestern parishes, Hanover, St. James, Trelawney, and St. Anne. And then also St. Thomas, you will see down the bottom where we've had problems before, you see that they are also having a high number of cases. If you look again at this slide to see how are deaths in your parish, then you will see that in every parish we've had COVID deaths, and the parishes that we've had the highest number of deaths are in St. James, in St. Catherine, and Kingston and St. Andrew. And if we look by rates in terms of the number of deaths per population in that parish, you will see that the number of cases per population is highest in Manchester, St. Elizabeth, Westmoreland, Hanover, St. James, Trelawney, and St. Anne. Now, this slide gives us the number of cases that we confirm each day, and this is what is in the blue, and you can see that certainly the 3 surges that we have had, with this last surge at the end of the graph being the highest surge so far, where we've had the highest number of cases. And the line that is in green and in red gives you the average, so you can see you can see the rise and the fall more clearly when you look at the line graph. And in the next slide, so this is a slide with the skyscrapers. And
Sorry,
so-
we distracted the CMOs. I apologize.
So certainly, I agree that anytime you're going to see these lines going higher than the skyscrapers, that we're in serious trouble. However, looking more closely at the slides, next slide, you can look at the next slide. What we're looking at here are the number of deaths that are in red. And a lot of questions lately about this, so I'm going to take a little time to just go through this. But certainly you can see that with every surge, we have had an increase in the number of deaths. And as the number of cases increase, the number of persons in hospital increases, the number of severe illnesses increases, and the number of severe outcomes increase. So certainly for this surge, which we hope we are at the peak at, or maybe have just passed the peak, then we would have seen that we have a higher number of deaths just because of the number of cases that we are seeing. Next slide. Now, over the last couple of weeks, we have looked at the deaths day by day, because there has been concern with regards to the fact that we did run into supply issues in terms of the oxygen supply to our hospitals over the weekend of August the 26th and 27th, or 27th and 28th. And what this is showing, I'm hoping that you can see where we have marked that weekend with some blue lines, so you can see the weekend, that weekend of the 27th, 28th, and the weekend after of the 4th and the 5th of September. And what you can see is that certainly in keeping with the rise in the number of cases, that the trend in terms of the rise in the number of deaths would be there. So we can clearly see that coming from the 1st of August, going up to about the 2nd of September, we would be seeing a slow rise in the number of deaths. And really and truly, for that period, August 1 to September 8th, we have had 465 deaths, which is a lot of deaths that have been related to COVID. And in addition, we have another 109 deaths that are under investigation. So there have been a significant number of deaths, as you saw in the previous slide with that very high peak in the red line, that there has been an increase in the number of deaths. So the general trend is that over this period, the numbers have increased, as we would expect with the increase in the number of cases. Now, we continue to collect the information from all the hospitals so that all the deaths can be investigated and we can classify and see if there is any associated factor related to the deaths. During the period when some hospitals were affected by reduced oxygen supplies, the public can be assured that all measures were put in place by the management teams to provide support to our patients. The pathology of severe COVID, however, is such that most deaths are going to result from respiratory failure or multi-organ involvement, and hence it will be difficult to say that a cause of death was due to reduced oxygen supplies. Next slide. In terms of our admissions, over time, you can see in the pink line indicates the number of admissions that have been increasing. And we see that with this third surge, that the number of admissions has certainly gone way past the number of admissions that we would have had in the second surge. Next slide. So with the average of over 110 admissions per day over the last couple of days, what we're seeing, of course, is that the number of beds that are occupied are increasing. And this slide looks at the number of beds that are occupied by both confirmed and suspected cases. And you would have seen that we would have passed the 700 beds that are designated for COVID care. We are now at over 1,100 beds that are occupied. So we are gone over that by about 400. Where are these patients? It certainly means that these patients now have to be housed in other wards that were not designated for COVID. And it means that we would have had to close some of our services that are offered in the hospitals to accommodate these patients that require this care in hospital. And so that puts a significant amount of pressure on the hospital system and the health system, because it means that if you have other illnesses that need to be investigated, if you have other illnesses that you need surgery for, then you will have to wait until we are able to clear some of these beds. And so persons have to recognize the fact that COVID and persons catching COVID does not just only impact on the persons with COVID, but once it affects the health system in this way, it certainly will impact the care of other illnesses. And so it makes sense that you prevent yourself from getting COVID and also prevent yourself from getting into problems such as road traffic accidents that are going to have a high demand on services in hospitals. Also, persons need to ensure that they're caring for their chronic illnesses, taking their medications, sticking to their diet, exercising. That will prevent them from going into crisis for other illnesses that will require hospital care. So in terms of the positivity rate, which is the proportion of our positive tests, or tests that are done that are positive. Now, when we looked at the slide with the number of confirmed cases, we certainly saw that we were heading up into a peak, but we did not clearly see that we were probably plateauing, leveling off, maybe even trending down. We can see that more clearly when we look at the positivity rate, because we know that when we went up to almost 50% positivity rate, and now we're at about 33%. So we can clearly see, looking at the positivity rate, that there is a trend that we are bending the corner, leveling off, and this is something that we hope that will continue, and we can see that this results in us going down the surge at this time. And here it is seen again, looking at the daily values. Again, you can see that there's a definite leveling off and hopefully a downward trend. Another good thing that we are seeing, apart from the positivity rate, is the reproductive rate. We would have seen that we would have gone almost as high as 1.5 with the reproductive rate. And what that means is that people were out there spreading. One person was spreading to several persons. We have imposed restrictions, and a lot of persons have taken on the personal responsibility to ensure that they restrain from behavior that will cause exposure and spread. And what we are seeing is that these measures would have resulted in a decrease in the reproductive rate. Now, it's still early days because we're just seeing the bend going down. And it means that we may have to continue with some of these restrictions that we have in place in order to keep that reproductive rate down and pretty much get it below 1. We want to get it back down to 0.7 and even below. 0.7 was where we were in July, and 0.3 was where we were at last year, July. So we want to get it back to down those levels. That would certainly indicate that the level of exposure in country is reduced, and that will certainly result in a reduction in our numbers. When we look at the vaccination coverage by parish, the vaccination, overall, we have 5.6% of the population that have completed their vaccination. We have another 11.6% of persons that would have received a first dose. So a total of 17.2% of persons that would have received, have some immunity conferred by vaccination, which means that there's 82.8% of the population that is still unvaccinated and are at risk. And this just looks at the age groups that have been vaccinated, and you can see that the 60 to 69, the 70 to 79 are where we have the highest level of coverage, but still needs a lot of improvement. And just want to say that we are still seeing that a number of the severe illnesses and deaths that we are seeing in hospital are occurring in the over 60 age group. And that is very unfortunate, because we would have opened up on the 10th of March, given priority to the over 60s to get vaccinated. And we shouldn't be seeing this at this time, because what we had hoped was that we would have had a higher level of vaccination. And so it's not too late. These persons need to come out and get vaccinated. They are at risk. We're still seeing high levels of severe illness and hospitalizations among this group. In the unvaccinated persons, we're seeing between 96 to 98% of persons in hospital are unvaccinated. And so we are now checking this on a daily basis, and that is where it ranges from. On a daily basis, 96, 97, 98% of persons are unvaccinated, meaning that they have not even received one dose. We have a few persons that would have received one dose of the vaccine, and very, very few persons that would have received 2 doses of the vaccine. Just to point out at this time that none of the persons that we've had with 2 doses or even 1 dose of the vaccine, none of the moderately or critically ill patients are in this group. And so what we are seeing is that the vaccine does protect against hospitalization, and it does protect against severe and critically ill cases. In terms of the total numbers of doses administered, we are now at 612,809, and this is at 5 p.m. today. The first doses, 59,040, and the second dose, 140, just over 141,000. We have over 12,000 persons that have received the Johnson & Johnson vaccine, and we really want to encourage the public. The Johnson & Johnson is a safe vaccine. It is very convenient. You only have to take 1 dose. It is safe in persons that are over the age of 18, in persons who have illnesses, comorbidities, persons who are immunocompromised, pregnant persons, persons that are breastfeeding. All these categories need to take the vaccines, and we are encouraging you to take the Johnson & Johnson. It's simpler, it's easier, it's 1 dose. So we encourage persons to take this vaccine. If you have any kind of question, we suggest that you discuss with your private practitioner and get some advice where this is concerned. In terms of the vaccination status, in terms of vaccine usage, we have used 465,126 doses of the AstraZeneca and 135,403 doses of the Pfizer vaccine and 12,280 doses of the Johnson & Johnson vaccine. We still have over 526,000 doses of vaccine in country to be administered, out of a total that was supplied of 1,139,140 doses. In terms of our supply projections for the rest of the year, September, October, November, we are slated to receive over 1.1 million additional doses of vaccine, and we will receive more of the Pfizer vaccine, the Sinopharm vaccine, the AstraZeneca vaccine, and the Johnson & Johnson vaccine. So there is a range of vaccines that are in country for persons there will be some choice, and you will be able to indicate which vaccine. Remember that for the 12 to 18 age group, it is only the Pfizer that is available for those persons. And our supply chain, therefore, is pretty good for the rest of the year. So again, we encourage persons to come and take the vaccine. Now, in terms of presently, our arrangement is that we will get a supply of the Pfizer vaccine once monthly for 3 months. We would have received the August supply, and we are anticipating the delivery of the second batch of Pfizer vaccines. However, because of the 21 days that is the time period for you to get your second dose, many persons will be due start doing their second dose on Saturday. And so because of that, what we may have to do, since we don't have a definite date on the arrival of the second batch, is we may have to halt the first doses and to apply the second doses, just to ensure that we have the second doses to give the persons who have received the first doses. But we do anticipate the arrival of the second batch soon. So therefore, in terms of our indicators, right now, you would notice a change here because we are now in the very high level of geographical spread. Over time, we have been in the there's a little bit of, in the medium, in the high level, but we have now gone over into the very high level, between 75 to 100% of our communities that are affected with COVID, newly confirmed cases over the last 2 weeks. In terms of bed occupancy, extremely high pressure, as we have indicated. 7-day positivity rate is trending down, but still at a very high level of transmission. Our reproductive rate, it's showing a positive trend in that it is going down, but we still have a low level of vaccination that is not having an effect on transmission as yet. So essentially, based on these indicators, we need to get our vaccination level up, which everyone can play a part in, and we need to get the spread down, which you can do by reducing exposure. Next slide. There has been a question, several times we've been asked this. Now that we think that we may be at the peak or just about the peak, how long before we are able to get back down to levels that we feel a lot more comfortable and have low levels of transmission? In the blue, what you will see is the first peak, the first surge, and the first surge took about 82 days overall, with a peak at about day 25. And it took about double that 25 days in order for us to get back down to low levels. So it took about 2 months to get back to the low level of transmission. For the second surge lasted for about 140 days, with the peak at about the 61st to 64th day. And again, it took about 2 months for us to get back down to a level below 10%. Now, the third peak that is in gray is higher. It's higher than the second peak. And so I think the best bet at this time is that it will take about at least 2 months for us to get down to that level below 10%. But based on the fact that the peak is higher, the variant that we're dealing with is highly transmissible, then it may take longer. But it is dependent on you. It is dependent on what you do in terms of reducing your exposure, in terms of getting vaccinated. Next slide. Next slide. Let's go to the next slide. So in terms of just to say again, any projection is going to be based on, in terms of how long, is going to be based on the variants that are in circulation. Delta is very, very transmissible, and so that can change how long we take to go down. And then if we get new variants that are transmitting even faster than the Delta, then that also can cause a lengthening of this surge. And it's also dependent on the measures we have in place. We have seen that the restrictions have been put in place, and we have seen a decrease in the reproductive rate. We have seen a decrease in the positivity rate. It is dependent on maintaining some of these restrictions, as well as how it is that we follow the protocols in terms of our own personal responsibility in keeping the numbers down. Okay, a word now on the variants. Next slide. So we have gotten back some results today, as Minister has indicated, and that has indicated that we have the mu variant that has been in the media for a couple of days now in country. These samples were samples that were taken from in August. They went off to the CDC on the 21st of August, and so the samples would have been from a few days before that. We will get a better idea of the time range and the persons that are involved, their age and which parishes, as we analyze the results. But we just got the results today, so we can share that we have 26 out of 92 samples that have shown the mu, or what they call a mu-like variant, and we have 55 samples that were delta. So delta variant still appears to be the predominant variant that we have in country now. Now, in terms of variants, what exactly are they? All viruses evolve over time, and most changes that occur in the viruses will have no impact or little impact on the virus's properties. However, some changes to the SARS-CoV-2 lead to variants of the virus, and that may affect virus transmissibility, disease severity, the efficacy of vaccines and other treatment methods. And so there is a need for continuous surveillance to check to see what are the variants that are there, what are the changes that they have, and what is the potential of those changes to affect some of these clinical things. And what we have two classifications that the WHO has indicated. A variant of concern, it says that the mutations have occurred, they have the potential to cause increased transmissibility, and they are causing increased transmissibility. They have the potential to cause some change in the clinical disease presentation, and they are doing that. A variant of interest indicates that the changes are there in the virus, but there has to be continued surveillance in order to determine if it is that there is an impact on transmissibility and severity of illness. So these variants of interest, of which mu is one, it's a variant of interest at this time, and so therefore it is being monitored closely by the WHO to see if it is that it has an impact on transmissibility and community spread, the amount of communities that are affected, and any severity of illness, and then also, importantly, if it has an effect on how the vaccines work. Just a reminder that we've had 4 variants of concern. The Alpha variant was the variant from the UK, which was more transmissible than the wild strain that we started off with. And then we had the Beta variant, which is the South African variant, which was also found to be to have a more severe illness in some instances, and was thought to have an increased transmissibility, but has not really developed in that we have not had a lot of cases across countries of this South African variant. And then we have the Gamma variant, which is the Brazilian variant, which also has shown to have some increased transmissibility, but still we're not seeing that widespread that we're having with that we had with the Alpha and with the Delta variant. And then we have the Delta variant, which was a variant that got its prominence in India, and that variant has spread to right across the world, and several countries are now, this is a major variant that is in those in countries. And then we have the variants of interest, and these variants are variants that have the potential to cause problems and are being monitored very, very closely to see if it is that they are causing this widespread. And so we have the Epsilon, the Zeta, the Eta, Theta, Iota, and Kappa, and now we have the Mu variant. Recently, we had heard of the Lambda variant, which there was quite a bit of publicity on, and this was first detected in Peru. And we had presented in this setting that several countries were affected, and there was evidence to show that the mutations could cause an increase in transmission, could cause an increase in severity of illness, and could also cause an evasion of the vaccine and how the vaccine works. However, next slide. what we saw that it had spread to a few countries, but we did not see that rapid spread that was associated with the variants of concern. And as a matter of fact, next slide, what we have seen is that the spread is not really causing any concern. As of 27th of August, there have been 8 confirmed cases in the UK. And at present, there is nothing to suggest that the symptoms of infection with this variant are different to other coronavirus strains. Next slide. We had detected 1,037 cases of Lambda in the USA, and the Lambda variant is not listed as a variant of interest by the CDC, but it is listed by the WHO. And next slide. So just to show how the Lambda variant that had caused so much concern when it first came about, it has slowly settled down and is not really showing that increased transmission or increased severity of illness. And now we have a new one on the block, and this is the Mu variant. And the Mu variant was first identified in Colombia. It has been designated as a variant of interest by the WHO. This was done on the 31st of August. It's the 5th variant of interest to be monitored by WHO since March of this year. Cases have been reported in UK, Europe, in the US, and Hong Kong. And the variant makes up less than 0.1% of COVID-19 infections globally. In Colombia and Ecuador, it accounts for 39% and 13% of COVID-19 cases. The Mu variant was detected in St. Vincent and the Grenadines, and they had detected 5 cases between July the 19th and August the 9th. And all cases were detected within the community as contacts of other positive cases. So we have detected it in some in Caribbean, and of course now Jamaica would report that we have some positive cases of this Mu variant. So while it is listed as a variant of interest and it has the potential to be of concern because of the potential increased immune escape, which is that it can evade the body's attempts to destroy the virus and to produce antibodies, and it can evade the antibodies. It has the potential for that. The Mu has mutations that might confirm some of these properties, but it is still being investigated. The WHO has said preliminarily that evidence suggests that the Mu variant could partially evade the antibodies we get from vaccination. So this is even more reason why it is that we need to decrease exposure. And it is also, the reason why it is that we would continue to have some travel restrictions on some countries. As you know, we have travel restrictions on some of the South American countries, and we would have been concerned about the Brazilian variant there, the Lambda variant, which started in Peru, and now we have the Mu variant that started in Colombia. So it is even more important for travelers to understand why it is that we impose quarantine measures, that they need to stay at home to decrease the risk of exposure, and to be tested appropriately so that we can pick up if there is any infection. The possibility of these variant strains coming into country is very, very real, and we're seeing that now with this detection of the Mu variant. So even more reason for restrictions and for quarantine. Another question has been asked repeatedly in terms of COVID testing and vaccination. Persons want to know if they need to have a pre-test before they take the COVID vaccination. And I believe that this is causing some persons to be concerned about whether or not they should take the vaccine. Now, the WHO recommendation is that a test is not required before being vaccinated. Clinical trial results have shown that people with previous COVID-19 infections can be vaccinated safely. the COVID-19 infection cannot be improved or treated by the vaccine. So a person with an unknown status at taking the vaccine does not turn out to end up having a worse case of COVID if they have COVID, or the vaccine does not cause them to have COVID. So there is no need for a pre-testing. However, we are advising persons that if you have been exposed to anyone with COVID-19 before being vaccinated and you have COVID-like symptoms or has tested positive for infection, then they should wait to be vaccinated until they have recovered from the acute illness and that they meet the criteria to stop isolation, and which for us, they have to be in isolation for 14 days. And so therefore they must complete their isolation period before they go and get their vaccine. So wait until your acute illness settles and your isolation period is completed before you go and take the vaccine. There is nothing to say that a person with unknown status, and that is a well person, turns out to have a worse case of COVID or to be affected by the vaccine because they could have had COVID, or that they end up with any severe illness or anything like that. So you don't need a pre-test, you can be vaccinated. In terms of this issue of permissive hypoxemia, again, something that has been put in the public space that we at the ministry would like to take the opportunity to comment on. We note with concern the article in a leading newspaper, read the management of patients at home with oxygen saturations as low as 60%. Now, this is a reminder to the general public that if you are being treated at home and your symptoms are worsening, then it is best to seek care from a medical practitioner. A word of caution to our doctors that the physiology of oxygen use in the body has not changed with the advent of COVID-19. Let us keep things simple. Tissues require oxygen to function, and there is a minimal level of blood oxygen that is required for adequate tissue function. Oxygen saturation levels below 90% for long periods is dangerous. There are various factors that will affect a person's ability to tolerate low oxygen levels. So if persons have other illnesses, such as if they are anemic, they may tolerate low oxygen levels worse than somebody else. Pulse oximetry, which is used in the pulse oximeter, the accuracy of this tool is highest at saturations of between 90 to 100%. It is dangerous to manage patients using a pulse oximeter when their levels are below 90%, as the arterial pressure of oxygen is not known. Doctors must exercise caution and practice within the scope of their knowledge and experience and refer patients appropriately. In response to another question in terms of surge capacity and the preparation of the ministry for this third surge, again, questions have been asked, and we just want to take the opportunity to respond to some of the questions in terms of how we would have prepared. Our 5 strategic areas in terms of response have been planning and coordination, situation monitoring and assessment, prevention and containment, health system response, and communication. And we review these strategic areas and prepare along these lines to improve the actions for any surge that we're going into or any activities. But I want to respond specifically to some areas. Next slide. And this is one in terms of bed capacity. We would have prepared 716 beds at the top of the last surge. And our general hospital occupancy is just over 5,000 beds. Now in May, we had 3 field hospitals that gave us some additional space. And at that time, we projected that another peak coming up in the summer months could result in over 1,000 persons on beds and that we would need additional beds. Now, in terms of our planning for this, one was to increase the bed space and to the getting in of more field hospitals, and we would have utilized our relationship with the U.S. South Command, and they would have brought in one more field hospital that is being currently erected in Maypen to add an additional 40 beds. And we would have also had an arrangement with a private donor who would have donated another field hospital on loan, and that is currently being erected in Savlamar. Now, in addition to that, we would have identified some new spaces in some hospitals where we would have been able to put in additional beds. And this was done in several of our hospitals. But moving on, as the numbers increase, then we recognized we had to convert existing wards by combining wards. And several hospitals did this by combining same-sex wards, putting female patients on one ward, reducing the number of patients, and therefore freeing up wards to accommodate COVID patients. As the numbers increased further, then we would have looked at reducing patient load. And when we went up to the 1,000, this is what we did in terms of our hospitals reverting to emergencies only. What this would mean is that outside of the 716 COVID beds, we would now start to use some of those 5,000 beds for the management of COVID. And so that is how we would have prepared in terms of the beds. In terms of ICU, HDU beds, in May, we had 12 ICU beds and 19 HDU beds that were for COVID. And we would have had 70 ventilators. Actually, that should be corrected to 108 ventilators. In terms of our third surge plan, what we recognized is that certainly once a patient gets onto a ventilator, the prognosis ends up being poorer. And so we would have moved to increase the number of high-flow nasal oxygen machines that we had in country, and therefore increased our capacity to decrease the use of ventilators. We would also have done the sourcing of additional ventilators. We have an additional 23 that was brought in through an arrangement with the Saudi government. We have now completed training where that is concerned, and so therefore the 108 ventilators that we have in country, we have an additional 20-odd of those now ready to deploy as needed. So we would have also taken steps to ensure that all our HDU and ICU spaces were functional and at optimal capacity. And this included some changes that we needed to make at National Chest Hospital, putting in some additional works at Spanish Town Hospital to be able to accommodate critically ill patients, the fixing of the air conditioning at the Victoria Jubilee Hospital, and our efforts to get an additional space at the Kingston Public Hospital prepared to manage these patients. So those were the things that we would have put in place. In terms of oxygen supply, we would have had our conversation with our suppliers in May of this year, and they would have indicated that they would have brought in 1,000 new oxygen cylinders in the March-April surge, and that they would bring in another 1,000 new cylinders to be able to meet the demand. Also at that time, they would have indicated that where it is that the demand for oxygen was at about 300,000 cubic meters over the 1 month period at the second peak, that they would have been able to provide up to 400,000 cubic meters if we go into a third surge. So that would have given us an idea how many patients that we could manage. But in addition to that, we would have at that time reached out to several of our donor agencies and bilateral partners in terms of securing oxygen concentrators. Now, this is a process that continues and has expanded. So far, we have brought in just over 20 of these oxygen concentrators that have been deployed to some of our hospitals. Right now, the issue that we had in August the 27th, 28th, was really an issue where the supply that we had expected to come in didn't come in. But since then, I just want to reassure the public that we have had adequate amount of oxygen that have come into country, just coming out of that weekend of the 27th to the 28th, where we had about 84,000 liters of oxygen that was brought in to supplement the 50 to 60,000 liters that IGL could produce in country. The following week after that, which was this week, we would have gotten the same amount in country, and next week we are getting an additional, it is anticipated an additional 120,000 liters. So this is adequate amounts to supply the numbers that we are seeing, and if there is an increase, then also we would be able to manage an additional number of cases. In terms of our staff, our nurses, at that time coming out of the March-April surge, we would have encouraged our regional health authorities to increase the employment of our nurses. We had new graduates where 261 registered nurses were expected to graduate, and up to the 24th of August, we would have employed 68 of these, with 102 more left to be that have been contacted and are ready to be employed. In addition, we would have taken up our midwives that would have graduated, or enrolled assistant nurses, and our patient care attendants, and we also had 20 critical care nurses that graduated from the program and would have been redeployed back to their areas of work. So we still suffer from the issue of migration, and up to August, the end of August, we had 166 nurses that have left for this year, but in replacement, we've had 180 that have been employed, and we have 102 that are awaiting employment now, with a potential to employ additional persons. We have also increased our training of our registered nurses in the basics of critical care nursing to enable them to assist in the management of critical care patients. In addition, we have 24 nurses that are supposed to come in the Cuba program, and these are supposed to come by the end of September. And in addition to this, we would have brought in some of our retirees, and we would have engaged our school nurses to assist in the vaccination program. In terms of medical officers, we would have engaged 53 additional medical officers who are assisting in the management of our patients. In terms of supplies, at that time, we would have also reached out to our donors through our foundation as well as through our partners, and so far we have been getting in supplies, and we are able to meet our supply demands. In terms of our testing capacity, we would have also anticipated that we would have been doing more testing at this time, and then we would have also secured those supplies. In addition, we would have supplied the machines to bring on more public sector hospitals, 10 additional hospitals, to do antigen testing, and so our capacity to do testing has increased. Those were the questions, Minister, that have been circulating and that we took the time to respond to. Thank you.
Thank you very much, CMO. You know, this was a lengthy presentation by our Chief Medical Officer. Lengthy, but I believe extremely necessary. Over the past few weeks, we have, I think, as a ministry, as a government, by extension, borne the brunt of some criticisms around our preparedness to deal with the third wave. There was, you know, critiquing of the plan, whether we had one. In fact, some even very influential entities and individuals have gone as far as say we have failed to plan and therefore plan to fail. And it has been difficult. It has been difficult for the team having had to deal with some of these criticisms. And it's a free country, so we're not criticizing criticisms, but the freedom to criticize. But, you know, to sort of bear the brunt of that along with the pressures on the system and to respond to the daily operational needs in the heights of this third wave has been quite stressful and difficult. And so we took the opportunity tonight not just to give an update, but to outline to the country that we have a plan. We've always had a plan. We have forecasted and anticipated what decisions came with what risks and what needed to be done to mitigate against those risks. And I really want to thank the CMO for her lengthy presentation, being extensive, because I think the country needs to know, because the confidence in the process, our response to this pandemic, the seriousness of it, the tragedy around loss of lives, we take very seriously. And I believe I say without any fear of, feeling otherwise, that the team spends significant amount of time planning, forecasting, anticipating, and preparing. Having said that, and you would have seen the elements of that plan presented today. And so I want to reject any assertion that somehow we have been wandering in the dark over the past 15, 16 months, stopping leaking holes as if we do not have capacity and have not applied that capacity to understanding the nature of an unfolding virus. There's no playbook for it. And have utilized the significant expertise that we have, drawing on assistance from multilaterals or people on the ground in the community or public health nurses and so on, to provide their best case scenario, to write that playbook and to project and to predict. It's not a precise science in predicting the virus and the direction, but there is a general understanding of how these things work. And we have always provided information around where we are, where we're going, what would happen if certain assumptions are made, if people followed the protocol, if they didn't, the worst case scenario. And we have always provided our best advice to the population. And it's important that the country appreciates that, because if they lose confidence in us, then the fear that has grappled the population over the past few weeks will only be amplified. And unfortunately, we will not provide the leadership that is expected to maneuver us through these very challenging times. And so I thank the CMO for that presentation, because I think it was important to outline the elements of the plan that we have had and that we have tried to implement over time. I want to say too that to the country that, we as leaders also have a responsibility to provide comfort, to provide some reassurance, which is why the plan is important, and people should know that there is a plan. It's not perfect, we're building on it, but there is one. But also that we are looking to the future to overcome. And some of the announcements we would have made, in addition to what we have been going through as a country, during the third wave, would create some despair, some fear, some hopelessness. And I want to reassure the country that there is reason to be hopeful. First of all, we're not in the dark spinning around as if we don't know what we're doing. We are making our best efforts to provide leadership at all levels, the government, the Prime Minister, the Cabinet, and certainly this team here in this room and the others who are not here. The lockdown period is bearing fruit. We're seeing positivity rates and reproductive rates coming down. That is reason to be hopeful, because the logical follow-on to that will be a reduction in hospitalization, and will then allow us the opportunity to begin to restore some sort of normality, because we understand the sacrifice that the country is making. The other hopeful thing I would like to say or comment on is the vaccination levels. As I said, we are at 612,000 doses, not individuals, doses, but there are over 435,000 first dosers. and many are due now. So once we complete that process over the next month, or most of them, we will jump from the 4.5 or so percent closer to 20%, 15 to 20%. And that will see us putting a dent in the fully vaccinated. That's encouraging because it means persons are coming out, they are taking up the vaccine. We do anticipate some hesitancy, but right now we're still dealing with accessibility. It's a very different thing. And that's why we're evolving and expanding the outlets. And the bottlenecks that we saw over the past few weeks was a result of some fear, primarily, where persons saw the deaths, saw the overcrowded hospitals, and many panicked, and that was a response. A positive response, nevertheless, but it created bottlenecks because you did not plan for it, because many did not register. But having recognized that and the need to move quickly, I think the Honorable Prime Minister has taken the right decision in evolving the process and announcing a team which I'll speak to. But this is a positive development. We will see an expansion in the fully vaccinated in a fairly substantial way over the next month, and that's something to be hopeful about. The other that I think is important is to overcome some of the fear associated with the new strain, the variant strain that was discovered. Now, the CMO has given a lengthy a lecture, if you will, in simple form, and appropriately so, on variant strains, because I was just observing some of the comments on social media while she was speaking, and the announcement of a variant strain, and this one in particular, will create some anxieties, and I understand why, and some panic. I think it's important to recognize that as an open society where we have both our diaspora and a tourism industry, it is very difficult to keep out variant strains as they spread across the globe, and certainly in countries that we are close to by virtue of relationships, whether relatives, friends, or visitors. And we can't lock those people out. We can screen, but the consequences of a total lockout will be otherwise very significant. But we should anticipate that these strains will come. And we should not panic about them, even though we will screen to avoid or reduce and test. What we should do is continue to observe the protocols, continue to take the vaccines, and build our capacity to resist as we restore some semblance of normality. And in this case, this new strain is a variant strain of interest, but it is not going to lead to more people dying or getting the infection. Right now, we're still studying it. So while we have an obligation to announce, we're not announcing for persons to panic. We're announcing for you to be aware and to recognize that this will happen. It's not a failure of the system or the process, but we should be prepared and understand what is happening, and we've always been transparent. So there is reason to be hopeful. There is reason to not panic, but be concerned and to take action. And I think it's important that that message be telecasted throughout the country, in your living rooms, in your companies, in the streets, in the communities, as we continue to manage this process going forward. I'll take a couple of quick things. We are building out capacity, which is another positive, with additional field hospitals. The University Hospital of the West Indies is building out a 60-bed facility, which we anticipate an expected completion in next month, October. This is a private sector UHWI initiative, and I want to recognize Mr. Gary Allen of the RGR Gleaner Group for helping to coordinate this effort, and working, of course, with the team at the University of the West Indies, University Hospital, and that process is in train. I did my little walkthrough this morning, and work is in full swing, and that's a positive thing in terms of additional capacity. The work has started also at Sub-Lamar Hospital to add 40 beds, and in Maypen Hospital similarly so, with Falmouth, St. Joseph's, and Spanish Town remaining operational. So there is additional capacity that is being built out, and that will ease some of the burden. I spoke earlier about the National COVID-19 Vaccination Operationalization Task Force, which the Honorable Prime Minister announced last week. And this task force is chaired by Professor Gordon Shirley of the Port Authority, and includes Professor Lloyd Waller of UWI, Colonel Lloyd of the Jamaica Defense Force, Peter Meledo of the Private Sector Group, ICD Group CEO, Alok Jan of the Consultant Office of the Prime Minister, and our own Permanent Secretary and CMO, as well as Dr. Sheila Campbell Forrester, a former CMO. And the Prime Minister, a release was sent out through OPM elaborating on the role of this group. And the simple explanation for it is that we are evolving into a process that allows us now with vaccines to expand the initiative, to bring more persons on board, and to drive a much faster pace of vaccination involving both the public and the private sector. Some may say why we didn't do it already. Well, we were always working through the private sector vaccine initiative chaired by Peter Meledo to put in the software. He played a big role there, to do interventions with private companies, and a lot of that has been going on. But given the targets that we have set, given the need to move forward, and very importantly, given the numbers of vaccines that we have and anticipate, we are now broadening that to create more opportunities. And this group will work with the Ministry of Health and Wellness to help to coordinate that, and it's a group that we fully endorse. Is Professor Gordon Shirley online? I want to just give him a few minutes just to officially introduce him to the COVID conversation. Prof. Shirley, how are you?
I'm good, Minister. Can you hear me?
I'm hearing you. No, yes, we're hearing you. Not going to keep you long. We know you're very busy, and with the new task assigned, must be, even busier. But just wanted to, first of all, thank you. I know the Prime Minister did that, and the team for coming on board and for working with us to expand this process. I'll just give you a minute or two to say what you think is important to those who may be listening.
Thank you, Minister. I would just want to underline some of what you have said, Minister. We are at a point where we have to accelerate the pace of vaccination. On average, since the start of our vaccination program, we are currently averaging maybe 100,000 per month or thereabouts, and that has to be increased to the order of 350 to 400,000 per month. And that process of increase brings with it additional challenges. And so this committee was established, this task force was established by the Honorable Prime Minister with an initial 7-month term of office, with a view to scaling up and streamlining both the public sector and private sector managed aspects of the national vaccination program, and to try to make it even more accessible, more efficient, and more seamless for the Jamaican people. Minister, you have already outlined the members of the task force or introduced them, and it is, I'm very honored to be working with such a talented group. Our targets or specific responsibilities as outlined in the terms of reference for the task force are to optimize the logistical and operational aspects of the vaccination program, from appointment system all the way through to vaccination and observation and post-vaccination administration, and to assist with and oversee the scheduling of the vaccination sites, the communication of vaccination sites, and so on. Second major responsibility is to assist with and develop and oversee the implementation of recruitment strategies that would bring suitably qualified and trained persons who are not currently within the public sector health system to assist with the scaling up of the national vaccination program. A third is to encourage and facilitate the participation of important stakeholder groups and various sectoral groups, such as those in tourism, the BPO, construction sector, and so on, to encourage their and facilitate their participation in the national vaccination program. And finally, we are charged with developing the authentication and system which will be linked with the Ministry of Health and Wellness's database to provide an unambiguous way of identifying persons who have been vaccinated. Importantly, Minister, the task force remit does not include the sourcing of vaccines into Jamaica. And although we have only been in operation for a few days, Minister, I think we have already begun work, and we are working and obtaining information from the ministry's team, including the permanent secretary and the CMO. We have met with various agencies. Today we were meeting with the head of the Irish vaccination program. They have already gotten to over 80% vaccination in a country a bit bigger than us, but not that much bigger. And they have some interesting lessons there. But the important thing is that ours is a unique environment, and we want to be able to, in this expansion program, ensure that we take the key features or key challenges into account to try to make it our objectives more realizable in time frame. Thank you, Minister.
Much, Prof. Shirley. Really appreciate it. Won't keep you much longer. I think you have outlined very clearly what this task force has been set up to do, and we welcome the additional team members to support the work that is already being done by the team here at the ministry. And in a sense, one could say that the National COVID-19 Vaccination Operationalization Task Force is an initiative whose time has come. People need to understand, I think it's important to say that public health, over the last 16 months, there's so many other things to do that at the end of the day it requires a service to people and to the institutions. I mean, there's the Cornwall Regional, there's building out of the IDB project, there are those with chronic illnesses. We really do need at this point, and I said it a few months ago, that we're going to have to mount the most significant national mobilization program, second perhaps only to a general election, where persons have to come out and are mobilized and are canvassed and are encouraged, obviously for a different reason. In this instance, it is even more important. It's a matter of life and death and really restoring normality. So we do appreciate the expertise of the additional capacity, and we look forward to really ramping up. I wanted to also mention that part of that ramping up involves trying to incentivize some of the communities and individuals to support the drive to get vaccinated. And we have started a vaccination incentive program, mobilizing the private sector to provide support to encourage persons to come out. Some have already started, some are already doing it, so it's not entirely new. We're trying to coordinate from our end to make it possible. To date, we have received gift vouchers, for example, approximately 2.24 million from 6 entities since we have started, from Grace Kennedy, Hilo Supermarkets, from Rainforest Seafoods, from JPS, from Digicel Foundation, well, Digicel, and this will be operationalized in selected communities in a manner that will see vouchers being given to particular segments of our population to incentivize take-up of vaccines, of course accompanied by all the protocols of giving advice and so on. We're not trying to lure people to take a vaccine without them understanding the benefits of it. So it's beyond just giving an incentive to be vaccinated. We encourage, first of all, I want to thank the companies that have come on board to date, and I want to encourage other companies to come on board. They can call 876-820-6019 or email CPHASC, that's CEPHASC, at moh.gov.jm if you want to play a role in encouraging vaccination in a selective context, then we encourage you to contact us and participate. Okay, are we still on, or we are? Okay, all right, so we got a little power cut there. In terms of vaccination access points, as part of the ministry's plans to expand the access points for vaccination, an invitation has been extended through a request. It's another initiative that we've launched, a request for quotation. So we have actually advertised to private companies and asked for a request for quotation to these private sector companies for participation in the vaccination program. The RFQ is aimed at including small, medium, and large enterprises that may be faith-based, community-based, or existing health facilities such as pharmacies, hospitals, health centers, or even doctors' offices. And the initiative will, as a clear objective, seek to expand the access points for different clients who will be able to receive their vaccination while shopping or while visiting their doctor's office. In other words, the RFQ, which is out, or you can get, I believe, on our website, will ask you for a proposal. If you're a pharmacy, a doctor's office, a hospital, and we have had training of our private hospitals over the last week or so, or an entity that can put together a team that satisfies some of the basic requirements of vaccination, so the protocols that are necessary. That proposal will be considered, and the government will offer, based on the proposal and what is being requested, will offer a payment incentive to that entity for persons that they inoculate, that they vaccinate. It will mean that they'd have to put that team together and meet those basic requirements. It would mean that they would be provided with oversight by the public health infrastructure. It would also mean that they maybe set a target so they can be mobile. They can go out to a community, to a company, but they would be compensated for each vaccine as long as all those protocols are met, uploading information, the technical protocols, and the oversight by the public system. The benefits of this clearly will mean greater involvement and participation in the vaccination process, more outlets for persons to get vaccinated, and hopefully drive the take-up that we have been desirous of having now that we have vaccines. And so if you need further information, then go to our website or contact us and we can provide you with that RFQ. The other area of expanded distribution or access are our mobile buses, and I'm happy to report that next week we will officially receive or the people, the Chinese government, the representatives here, will officially hand over, even though we have been in possession, we have prepared, wrapped, and so on, 2 mobile buses that will be used to go into the field, selected locations, and to administer vaccines. So we are making progress in terms of the expansion of the approach, and with the team coming on board, chaired by Professor Shirley, and the work that we have already done and are doing, I think that achieving vaccination will be a lot easier. The issue now is to convince as many Jamaicans as possible to come out. I think that's it for now. We've been at it for a long time, so I'll hand over to you now, Stephen, for any questions.
Thank you very much, Minister. Just reminding our media colleagues to use the raised hand feature on Zoom to pose your questions. We're going to begin with Kimo and Francis from the Gleaner.
Thanks, Stephen. Good evening, Minister, CMO, colleagues. 2 questions. What numbers are there for child hospitalization, and what percentage of people who have been due for second shots have not taken them with the period expired? And how is the ministry addressing this?
Right. I'm not going to be able to give you the exact number on child hospitalizations right now, but I'll see if somebody will provide the answer during the course of the rest of the conversations. But I can say that in the 0 to 9 age group, it is just about 5.3% of confirmed cases that would be in that age group. And for the 10 to 19 age group, we have had about 7.7% being in that age group. I can also say that in terms of deaths, we have had 3 deaths in the less than 10 age group, which represents 0.2% of deaths, and a case fatality rate of 0.2%. And in the 10 to 9 age group, we have had 8 deaths, and represent 0.5% of deaths with a case fatality rate of 0.2%. If I get the numbers on the hospitalization, I will let you know.
Thank you very much, CMO. We're going to go to Christopher Thomas from the Gleaner.
Yes, good evening, Dr. Tufton and your colleagues. I have 2 questions. How does the ministry intend, first of all, how does the ministry intend to address the concerns and reports that are arriving about frontline hospital workers, the junior doctors and nurses, not having the adequate equipment that they need, like face masks, especially in light of 53 nurses that have tested positive very recently at Cornwall Regional Hospital? That's the first question. And second question is following up on what Dr. Bisesa Mackenzie was saying earlier about pre-testing not needed for vaccination. What about persons who they would have developed antibodies from previous COVID infection? Would they still have to get, or would you still recommend that they go get the vaccine anyway?
All right. Well, certainly in terms of our supplies, we at the ministry have not been notified, and we have our regular meetings with our regional technical directors, with our senior medical officers. We have not been made aware of any shortages, and what I really would suggest for these persons who face an individual challenge or even a challenge in a particular hospital, for them to have a discussion with the senior medical officer, so that we can address the issues, because we know that we have adequate supplies in Ireland. From time to time, we have had, in our last report, we have had 1 or 2 situations where there was a particular size of masks that was out of stock, but the persons reported that they have gotten it back in stock. So we certainly would want to address any issues that there are as soon as possible. And I would really, really appeal to these persons that they have the discussions with the SMOs, with the CEOs, with the health departments, so that we can address the issues, you know, confront these problems. Thank you. In terms of the, what was the question?
The antibodies.
Okay, right. So the fact is that persons who have had an infection will develop some natural immunity. And the studies that we have seen have shown that that immunity, some reports are saying up to 6 months that they will have protection. We have even seen reports that have said over up to a year. And as time goes by, I'm sure we will see different studies reporting on that. However, what we have to recognize is that the certainty of the response and the level of response is unpredictable, and so we can't say for sure that everybody that would have been exposed would have had a 6-month immunity. And so while it is that some persons may choose to wait 6 months, and I've heard persons say wait 4 months to have that vaccine dose, they have to be aware that right now we have the prevailing variant, the Delta variant. There may be some re-exposure to other variants, and the recommendation from the WHO is that yes, there is a 6-month period that persons can say we have natural immunity, but they are recommending that persons who choose to wait no more than 3 months or 90 days because there is the possibility of being reinfected. And so that is the recommendation. If you choose to wait, don't wait more than 3 months to get the vaccine. But you don't have to wait 3 months to get the vaccine. Once your symptoms have settled, you have completed your isolation period, you can get the vaccine. Okay?
Thank you very much, Simo. We go to Althea Saunders from the Jamaica Observer.
Good evening. Regarding the Pfizer vaccine, I'm trying to rationalize the numbers. You said that 135,403 doses have been used. Are those single doses? I'm looking at the balance of 72,000 odd that are left. If those are single doses, do you have enough to administer to the persons who will be returning for the second dose? And how many persons are due for second dose on Saturday coming, I believe you said?
All right, good afternoon. You're right. The amount of doses that we have utilized are single doses. So we have utilized 130,000 single doses of the 208,000 or so doses that we have received from the donation from America. And that is why we have decided, given the fact that we don't have a definitive date from the Americans in terms of the arrival of the second supply, that we would restrict the balance that we have of 70,000 to the persons who are receiving their second dose of Pfizer. And so what we are proposing is that we continue with the application of the second dose on Saturday, and then once we receive the additional supplies from the shipment from the United States, we would then begin again the administration of first doses. But at this time, given the uncertainty around the arrival date for the shipment of the second shipment of the Pfizer vaccines, we will be restricting the remaining balances to second dose administration.
We're going to go to Roxroy McLean from the Gleaner.
Good evening, Mr. Tufton, CMO, colleagues, good evening. I have two questions. One, how does the emergence of the new strain affect our quest to achieve herd immunity by next March? Also, for clarity, are there any considerations for an increase in 65% target that has been set? And two, Minister Tufton, how do you respond to cynics who question whether people still dying from heart disease, cancer, high blood pressure, etc.? They feel that every death is now being labeled having been caused by COVID-19.
The first question was, repeat the first question for me, please.
The emergence of new strain, how does the emergence of new strain affect our quest to achieve herd immunity?
Herd immunity,
by
right.
March?
And whether or not we're revising the 65% by March.
Yes.
You want to go ahead with the herd immunity?
Right. So you would have seen that various countries would have been relooking at these numbers, especially in light of countries that would have achieved over 70% vaccination and would still be seeing increase in the number of cases. And this just, is showing how things are evolving over time. Certainly when we started out looking at the reproductive rate of the virus at the time and looking at the strain that was there at the time, the prediction was that in the region of 65 to 70% of persons with immunity that you would achieve herd immunity. I think that things have changed since that, and certainly with the new strains that are there, reinfections that are happening, it is clear that we may have to achieve more than that. So in order to get immunity, and then there is no guarantee as to how long that immunity will last. So certainly the information is changing, and we have to revise what is the level of protection. What we do know is that vaccination does afford protection, and in particular, even if it is that we have persons getting reinfected or getting for a first infection after having the COVID vaccine, what we have seen is that the studies are still showing that they are very effective against preventing severe disease, hospitalization, and deaths. So there is a clear benefit for getting the vaccine, and again, I would encourage persons to do so.
The question that you directed at me was about hypertension and people dying and attributing it to COVID. I'm not hearing you.
Yes. How do you respond to cynics who question whether people still dying from heart disease, cancer, high blood pressure, etc.? They feel that every death is now being labeled having been caused by COVID-19.
I don't think the clinicians do that. I mean, CMO can comment on that, but we are very clear in terms of, I think we have enough capacity within the public health system to determine. What we have always said is that the underlying conditions make situations worse, and that most of those who have died are of a particular age with one or more with comorbidities. But I think that is almost universal. So I'm not sure why one would be cynical about those conclusions when it's clinically determined, and those underlying conditions are normally a matter of record based on person's medical history or determined at that point in time. So I don't know, CMO, I don't know if you want to add to that, but I've never heard persons being cynical around that. I mean, maybe you have.
Just to add that, in everything you do, there is a margin of error. And in classifying deaths, I mean, one can, in some situations, it's very clear-cut, that the cause of death but in many situations, and that's why if you see how the medical report is written, you know, it's death as a result of, which is as a result of, which is as a result of. You know, so there is some margin of error, and clearly there are a lot of persons who have chronic illnesses and even just age-related issues that contribute significant to them having a poor outcome. We go through a process of investigation of all the deaths, and we look to see if there is any reason why we would suspect that this person who is COVID positive, if their presentation to hospital, their symptoms leading up to their death could be related to COVID or to something else. And then we make our best judgment as to, you know, the classification, whether it is COVID related, whether it is a coincidentally a death in a COVID positive person. And some of them really and truly, you're not able to classify at some point because you can't really make the decision. And we have a few cases that it has been very difficult to classify. So there's always a margin of error, but we do our best, and we have a good team of persons that are working with a lot of experience. We look at the investigation involves looking at the clinical records and in interrogation of the data and discussions with the persons who manage the patient sometimes to make that decision. So it is a process, and you have to expect that there will be some margin of error. Yeah.
Thank you very much, CMO. I'm going to go to Emma Lewis.
Yes, good evening, everyone. I have a question regarding senior citizens. I'd like to know whether you're satisfied regarding the vaccination levels for the over 60 age group, and how that is actually how that's going in terms of vaccinations. Also, senior citizens who are in old people's homes, and also those who are shut in at home, who actually can't get to a vaccination center. How are you dealing with those? That's my question. Thank you.
Okay, well, certainly you saw the figures that we presented earlier that showed that despite the fact that we have the over 60 age group representing the largest numbers, there's still a significant number of them that are unvaccinated. And again, the reflection that a large number of deaths that we are seeing at this time are in unvaccinated over 60s. And so we can't say more that more persons need to be vaccinated. We will launch our site for the registration of persons who are shut-ins. Very shortly we will launch that so that persons can register, or persons they know can register them, so that we can make arrangements for them to be vaccinated. And this is one of the things that we have been working on and will roll out very shortly.
Thank you very much, Simo. We're going to go to Zara Burton.
Good evening, everybody. My question is for the CMO. It's a two-part question. Given that the CDC, I guess some months ago, there was a document by the CDC that said that vaccinated people that are infected with Delta have viral loads, measurable viral loads that are similar to those who are unvaccinated. In addition, it said that while the vaccinated are less likely to get sick, they might be just as likely to pass the disease to others. So my first part of the question is, if that be the case, if that is something that you accept, and I'm not sure you do, but I'm just asking, if it's something you accept, why is there an 8-day quarantine for vaccinated persons versus a 14-day quarantine for unvaccinated persons when they come from abroad? That's part one. Part two, medically, is there a risk for the vaccinated to be around the unvaccinated? And how so, if yes?
Okay, well, first of all, I'm going to take your word for what that CDC document says. I have not seen it myself. But, you know, we have always said that the vaccinated does pose a risk, and therefore our insistence on quarantine measures. So that is something that we believe in, that it is really the measures in terms of preventing exposure that are really going to be effective in preventing transmission. And so we have said that the vaccinated persons need to ensure that they are wearing their mask and they are adhering to all the other measures, because they can transmit. Now, we have not seen definitive evidence in terms of how much they transmit and how well they transmit. We haven't seen definitive evidence where that is concerned, but I think it is internationally agreed that there is some transmission that persons who are vaccinated will still be able to pass on. And we know that these persons are still at risk of developing COVID, even though it is mild COVID. And so therefore, if they are infected, then they can shed some virus and therefore are able to infect others, even though their viral load may be low. Although I hear you saying that the CDC has said that with the Delta, the viral load is the same, which would mean that there is even more risk. So our advocacy is for the quarantine. The quarantine period is important, and persons need to be monitored, both in terms of adhering to the rules and, of course, their own personal responsibility to prevent the spread of the infection. What was the second thing?
Thank you very much, Seymour. Final question is coming from Owen Roberts from Roots FM.
Good evening. Good evening. Yes, I have just about 3 questions. But first, in an update regarding the training of school nurses and private hospitals, how many nurses were trained, and are they being utilized now? For private hospitals, what's the update on that? 2, well, we can say 3. The app that was, touted by the minister, regarding inoculation. How widely is this app used, and how often is it updated? Because we're not hearing much about the use of the app. Are there persons trained in using and getting the information and passing it on to the ministry? And finally, will the ministry, to some extent, change their messaging or response since the Moon variant has been confirmed in Jamaica?
I think, is Dr. Ennis online? She could answer the question on the nurses. Dr. Ennis? If you are, I'm sorry, I didn't introduce you before. Is she on?
Minister, good night, everyone. Yes.
I'm sorry about that. I didn't know you were on earlier. Stephen just mentioned to me I should have introduced you earlier. Can you answer that question for us, please? Thank you.
Thank you for the question. So we started our training of persons in the private hospitals as well as our school nurses, and we have done over 165 persons to date. Of that number, 57 are school nurses. We have started to deploy, and they will so be assisting in the vaccination program within schools on the weekend as we begin to administer the second dose of the Pfizer vaccine. We also have another training for additional school nurses as well as nurses from the training institutions, and that will take place tomorrow. With regards to the private sector hospitals that are on board, we have shared information, we have done site visits. few of the facilities, we are engaging and have engaged in ensuring that the needs are met in short order. So they should be coming on stream in due course, in the course of this month, actually.
Thank you. It's an important question. There is active engagement with alternative vaccine locations, independent operators, if you will, clearly with the oversight of the ministry. And what Dr. Ennis is reaffirming is that we have actually trained a number of school nurses, and we have trained a number of private hospitals. In fact, I had a meeting with the private hospitals, I think about 9 of them throughout the country, 9 or 10. So the Medical Associates and the Hargreaves and the Andrews and so on. And some are quite small, small facilities in some of the other parishes, 5 beds, but they have the infrastructure, and it's just a matter of acquainting them with the protocols and ensuring that that infrastructure is complete. So whether they need to add a particular refrigeration to store, that kind of thing. And the intention is to engage those that want to be. Not all of them want to be engaged. Let me just be clear. It's not that you have a lot of people offering themselves. And the RFQ that we have put out, we hope, will interest more persons. There are some bottlenecks. The need to have healthcare workers, for example, who are trained to administer vaccines, the infrastructure like the refrigeration equipment. But to the extent that they are available, the opportunity exists for them to come on board. And the intention clearly is to have greater throughput so we can achieve our objective over time. You ask about the app, and we don't, we're not, the manifestations of the app are clearly in the data that we put out. So we don't reference the app when we're putting out the data clearly. The PS just spoke to the numbers as of 5 o'clock today. The app gives us real-time information, and that information is both for public consumption, those announcements that have been made, but it's also very importantly for planning. So we know exactly what is happening at a particular point in time, in a particular parish or at a particular center. So the app is active and is being used. And we are trying to add additional features to it. For example, persons who have been vaccinated overseas and who would have declared, then we'll add them to the numbers to get a better picture, a more accurate picture of the vaccinated. So the app is working, and the manifestation there is in the data that we've been able to put out, and for planning purposes. The messaging and change because of the new variant, the communication strategy and communication tactic, if you will, shorter term responsiveness evolves and has to evolve over time. And so what you would have seen last week or a month ago is not what you're seeing today. It requires constant attention. It requires pulling information in to determine, what the public perception is. Right now, for example, we need to do more on the Johnson & Johnson vaccines because we are a little concerned that the take-up of Johnson & Johnson is not as brisk as we would like. Now, we had anticipated that a single dose would be an encouragement to some because there are a number of persons who are afraid of the needle. But we're not experiencing that as much as I think we should, even though we are evolving. The Johnson & Johnson is best suited for some of the community engagements where you don't have to double back for a second dose. So we have a plan, but I think we're going to have to do more to educate, inform the public around that particular brand and why it is as good as any other. And the added advantage clearly is that you have one dose applied, which is the full dose. So there is the need for that. Now we have the new variant. We're going to have to give some information. The CMO has given amazing information, very adequate. And we're now going to have to break that out, simplify it, get the country to appreciate and understand. So you're seeing the beginning of that process, and it starts at the right place. It starts with the clinical head and her team, and then it will be filtered down to the communication practitioners who will simplify and get it out, whether through flyers or in the communities, loudspeakers, and so on. The testimonials and so on are good. You know, I've heard, you know, again, we've spoken about the need for a budget for communication, and in fairness, we have been managing. The call for more to be done sometimes, I think, is valid. In other times, I think is not so valid. It is true that you have to have a budget, and those who criticize the budget and say we should do free communication and, you know, have MPs put out the messaging, I mean, that's all well and good, and we need to encourage that. But, you know, this is serious assessment of perception and a response to perception in order to facilitate take-up. Private companies spend millions of dollars on communication, and they're trying to do the very same thing that we're trying to do to get a service taken up, a product, in this instance vaccines, accepted. And if they spend millions, I'm not sure why persons are suspicious or critical of government doing the same to communicate effectively. Clearly there needs to be transparency and accountability, that goes without saying, but the strategy has to evolve over time and adjusted as necessary, depending on what we pick up on the ground. And we do polls to try and measure some of that perception in terms of brand selection, brand preference, access, ease of access, suspicions around the vaccine, you know, misinformation, that kind of thing. And it's an ongoing daily occurrence. And so, yes, it is subject to change and to evolve over time.
Thank you very much, Minister. Those are all the questions we have from our media colleagues. So I'll hand over to you for your closing remarks.
Well, we have been at this for a very long time. Not much more to say. Thank you very much. We will continue to provide information. We'll break out some of the presentations that have been put to you today. The CMO's excellent and in-depth presentation, some of the things that I have said and the PS. And so we'll simplify that, and we will have one-on-one conversations with the media as we go forward. Appreciate the time. Continue, please, to observe the protocols, take your vaccines, and let's come together as a country. There is light at the end of the tunnel. We will beat COVID-19, and that is a commitment from all of us on behalf of all of us. Thank you very much. God bless.
Hello, Jamaica. I'm Dion Jacksmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness.